Drugs for treating musculoskeletal and neurological conditions. When students complete this content, they should be able to distinguish between different causes of articular or joint pain. Provide examples of medications used to treat joint pain. Differentiate between the different classes of drugs for treating arthritis. Discuss advantages and disadvantages of drugs used to treat musculotendinous pain. List the drugs used for treating neck and back pain. Provide examples of drugs for treating fibromyalgia and complex regional pain syndrome, and identify drugs for treating headache disorders. The athletic trainer encounters many conditions of the nervous system and musculoskeletal systems. Conditions range from those that are acute, such as fractures, sprains, and strains, to lifelong conditions associated with chronic pain and disability, such as migraine, rheumatoid arthritis, and even fibromyalgia. We will explore examples of drugs used to treat arthralgia and pain resulting in injury from acute infections of arthritis and osteomyelitis, gout, osteoarthritis, or degenerative joint disease, rheumatoid arthritis, and systemic lupus. Septic arthritis is typically treated with IV antibiotics in severe cases, either gram-positive bacteria or gram-negative bacteria. Osteomyelitis requires debridement and IV antibiotics, usually a 4 to 8 week course of antibiotics. Gout requires NSAIDs or cholecystine. Typically, we will treat gout with several days of medicine to prevent a relapse. Osteoarthritis is a potential loss of joint cartilage and osteophyte formation. Typically, we treat this with over-the-counter medication or prescription medication. Some opt for nutritional supplements, hyaluronic acid, and joint lubrication injections, typically 2 injections over a period of time. Rheumatoid arthritis is a chronic systemic autoimmune disorder or disease that primarily involves the inflammation of the synovial membrane, which becomes inflamed and thickened. Next, the fluid builds up and the joints erode and degrade, causing pain, swelling, and deformity. The precise cause of rheumatoid arthritis is unknown, but many factors may contribute to it. The treatment of rheumatoid arthritis involves a balance of rest and exercise, adequate nutrition, physical measures, drugs, and sometimes surgery. The goal is to reduce inflammation as a means of preventing erosion, progressive deformity, and a loss of the joint function. Almost all patients are treated early and primarily with drugs that modify the disease activity. Disease-modifying anti-rheumatic drugs, or DMARDs, are used to treat rheumatoid arthritis. NSAIDs can be used to limit utility. NSAIDs do not prevent disease progression and are used as an adjunctive therapy. Corticosteroids, such as prednisone, can be incorporated, and non-pharmaceutical options, such as rest, may be incorporated and preferred as opposed to surgery in some cases. Musculoskeletal and musculotendinous pain. The most common cause of periarticular pain is injury, including overuse pain relating to the musculotendinous structures. Common musculotendinous disorders include bursitis, tendinitis, and epicondylitis. Periarticular infection is less common. Pain primarily occurs with activity. Tendinitis is inflammation of the tendon. Tenosynovitis is inflammation of the tendon sheath lining. We typically treat these with over-the-counter or prescription medications along with various therapies. Pain can be relieved by rest or immobilization of the tendon, application of heat or cold, followed by exercise. Analgesics such as acetaminophen and high-dose NSAIDs are typically administered for 5 to 7 days. However, for pain that persists after seemingly minor injuries, the athletic trainer should refer the patient to a sports medicine specialist for evaluation to see if additional or more severe injuries are present. These injuries may be treated as appropriately with NSAIDs and sometimes with oral or injectable corticosteroids. Corticosteroids should be injected by a skilled practitioner and only given when necessary. Corticosteroids should not be injected into a tendon because they can delay soft tissue healing and weaken injured tendons and muscles. Additionally, the frequency of corticosteroid injections should be monitored because too frequent injections may increase the risk of tissue degeneration and ligament or tendon rupture. We may inject a sustained-release corticosteroid in the tendon sheath, which may help with pain and inflammation. Injection is usually indicated if pain is severe or the problem has been chronic. Specialized clinicians should be careful not to inject the tendon. Patients are advised to rest the adjacent joint to reduce the risk of tendon rupture. Infrequently, symptoms can worsen for up to 24 hours after the injection. Additional injections and symptomatic treatment may be required. Neck pain and back pain are among the most common reasons for acute and chronic musculoskeletal pain, with or without radicular pain. Depending on the underlying cause, neck or back pain may be accompanied by neurological symptoms. If a nerve root is affected, pain may radiate distally along the distribution of that nerve root, also known as a radiculopathy, resulting in radicular pain, weakness, numbness, or difficulty controlling specific muscles. Counterirritants, the sense of warm or cold, may help to improve blood flow and reduce inflammation. Over-the-counter NSAIDs or prescription NSAIDs might be helpful. The use of muscle relaxants might be indicated if palpable muscle spasms are felt, but we need to be cautious for adverse effects. The use of corticosteroids might be useful for radicular pain. Antidepressants might be helpful, but they are unproven with limited evidence. Because of their potential for addiction, opioids should only be used for short periods of time and under the physician's supervision. Some evidence exists for the short-term efficacy of the use of opioids to treat chronic low back pain compared to placebos. Physicians should exercise extreme caution in prescribing a trial of opioids for long-term pain management due to the potential risk of opioid abuse. Fibromyalgia is a common non-articular disorder of an unknown cause, characterized by generalized aching, sometimes severe, widespread tenderness of muscles or muscle stiffness, fatigue, mental cloudiness, poor sleep, and a variety of other somatic symptoms. Symptoms and signs of fibromyalgia are generalized. This contrasts with localized soft tissue pain and tenderness, which is often related to overuse or microtrauma. Stiffness and pain frequently begin gradually and diffusely, and the pain has an achy quality. There is no single best choice of medicine to treat fibromyalgia. Acetaminophen or NSAIDs may help. Some sedating drugs or antidepressants may help improve sleep quality. No evidence of opioid utility has been demonstrated. Occasionally, anesthetic injections can help treat focal tenderness, but such injections should not be relied upon as the primary treatment because evidence does not support their regular use. Complex regional pain syndrome, formerly called reflex sympathy dystrophy, or causalgia, is a chronic neuropathic pain that follows soft tissue or bone injury or nerve injury and lasts longer and is more severe than what is expected for the original tissue damage. The key symptom of complex regional pain syndrome is the prolonged severe pain that may be consistent. The pain that can be described as a burning or pins and needles sensation, or the feeling that someone is squeezing the affected limb. There is often an increased sensitivity in the affected area, in which normal contact with the skin is experienced as very painful. NSAIDs generally are the first line of defense, and opioids are often considered an early option. And anticonvulsants treat neuropathic pain and nerve damage. Corticosteroids may help to reduce inflammation. A sympathetic nerve block may be utilized as an anesthetic injection for regional pain. Anesthetics such as ketamine may relieve pain, but unfortunately do not improve the patient's function. A headache is a pain of any part of the head. Headache disorders are characterized by recurrent headaches. They are among the most common disorders of the nervous system. A headache is a result of an activation of a pain-sensitive structure in or around the brain, skull, face, sinuses, or teeth. Some causes of headache are common. Others are important to recognize because they can be dangerous, requiring specific treatment or both. In the cases of concussion, give the patient no aspirin. We can provide NSAIDs, occasionally opioids. Acetaminophen is okay to provide. Migraines are a headache disorder with symptoms that typically last 4 to 72 hours and may be severe. The pain is often unilateral, throbbing, and worse with exertion. Headache symptoms may be accompanied by nausea and sensitivity to light, sound, and odors. Auras accompany migraine headaches in about 25% of patients. Emergency use Toradol injections can often be used in an emergency department. However, if used for too long, the medication can cause overuse headaches and possibly ulcers and bleeding in the gastrointestinal tract. Vasoconstrictors, such as Imitrex, are effective for treating migraines because they block pain pathways in the brain. However, they may not be safe for patients at risk for stroke and heart attack. Vasoconstrictors are most effective when taken shortly after the start of migraine symptoms that tend to last for longer than 24 hours. Anti-nausea drugs can help a migraine with aura that is accompanied by nausea and vomiting. A tension headache may be episodic or chronic. For tension headaches, practice self-care. We can provide some medications and other therapies. Over-the-counter NSAIDs or acetaminophen are options, but neither is better than the other. In summary, chronic muscular and neurological conditions can cause long-term pain. We should review drugs for various situations that the athletic trainer must be familiar with, and medications must be adjuncts with other therapies.